warm welcome to all our viewers to today's special session of International Faculty Webinar. We have a very distinguished guest and speaker today, Professor Massimo Antonelli. So, sir is actually Professor of Intensive Care and Anesthesiology. He is Director of the Department of Emergency Intensive Care and Anesthesiology of the Fondazione Policlinico e Gemelli University Hospital, IRCCS, Catholic University, Rome. Sir has been a very distinguished past president of the European Society of Intensive Care Medicine and former editor-in-chief of the Intensive Care Medicine Journal. And he is a European Society of Intensive Care Medal recipient. He has done remarkable research work, and his work has contributed greatly to today's intensive care medicine. He is the author of more than 700 papers with H-index 113. And research interests are sepsis, infection, mechanical ventilation, and ARDS. So today, sir will talk to us on sepsis phenotypes, and it is my great privilege to welcome you, sir. Please start the session, sir. Thank you very much.
Thank you very much, Dr. Bansal. I think it's really an honor, and thank you for the introduction. And I try to spend the next 45 minutes or so just let me share. The point is that today the main topic will be the identification or the tentative identification of sepsis phenotypes. I want to start with a sepsis definition for pointing out a couple of very important things. As soon as we define a sepsis as a life-threatening organ dysfunction caused by a dysregulated host response to infection, we immediately say that is an emergent situation where we need to act rapidly in order to save the life of our patients. And connected to that, to the response, this dysregulated response to infection on part of the host, we have a development of hypoperfusion and organ dysfunction that can be identified at least looking to the SOFA score, sepsis organ failure assessment score above 2. So, two main concepts. This is an emergency. There is the dysregulated host response to infection, and the consequence is an organ dysfunction. If we refer to the patient with septic shock, we identified a clinical construct of sepsis where there is a persisting hypotension requiring vasopressors. But the other elements that enter into this definition are certainly the high level of serum lactate, once again testifying the variation of the metabolism from aerobic to anaerobic pathway into the tissue, and this is notwithstanding the volume resuscitation. We know that the mortality rate in this case is very high. And we know also that we have 4 pillars for the sepsis where our interventions intercept the different derangement of the various organ and oblige us to identify early the source control in order to put under control the origin of sepsis, the real source. This can be achieved in many different ways, but once again, if we include into the definition the idea of supporting artificially the organs, we implicitly look at the different concept of hypoperfusion and its declination. But let's move to the main topic of this intervention. Why do phenotypes matters? The main concept is related to the fact that whilst, for instance, the oncologists that treat a real phenotype or endotype, because they do have a disease, when we refer to the sepsis, we are not speaking about a disease, but a syndrome, which is caused by different pathogens in different hosts with different immune response and different organ dysfunction, and finally a different outcome. In other terms, our intervention that may just devoted to finding out a therapy that could fit for all, indeed can be translated only in a failure because of these differences. And at the same time, as soon as the sepsis develops, we have a hyperinflammation pattern, an immunosuppression, the involvement of the endothelial dysfunction and microvascular injury, and coagulopathy and thrombosis. So we do have a different biology, a different trajectory, and a different therapy for our conditions. The heterogeneity of sepsis is related to the multiplicity of the sources and the variable shape for every distinct phenotypes, starting from the host, the age, the frailty, the comorbidities and genetics and immunostatus characterize different conditions, as well as it's true for the infections that can be caused by bacteria, viruses, or fungi. And the source is not always the same. We can have a sepsis and a severe infection that characterize a typical phenotypes in the lung, in the abdomen, in the urinary tract or bloodstream, wherever. And another important factor that plays a major role is the timing. In the same patient, in the same phenotype, you may have an early phase with hyperinflammation, and then gradually, over time, a transition, if the syndrome persists, into a sort of immunosuppression that, if it is solved in a positive way, will lead to a recovery. The clinical impact may look at the severity score, similar severity score, but at the same time, a different biology and a different outcomes. What is a phenotype? We have to look at the observation, to the mechanism, to the therapy. The clinical phenotype is what we observe at the bedside. Examples: shock, ARDS, hyperlactasemia. And then we have the endotype. What does it mean? That there is an underlying biological mechanism that takes an action. And in this case, we may have an activation of the macrophages, the immunoparalysis, or the involvement of the endothelium. It is more intuitive that these different conditions may characterize the kind of therapy we have to, in way or another, use, and then its response to the therapy. And then we move over time from the syndrome, looking at the mechanism and a targeted treatment. There was an evolution of sepsis classification. If you remember, we had an old paradigm that is the traditional, looking at infection, the development of systemic inflammatory response syndrome, as it has been defined into the ancient times or in the previous years, and the development of sepsis identified by the organ dysfunction. The current paradigm look at the precision of a critical care. Why? Because we have to look at the different kind of infection and mostly to the host response. Why? Because the host response may follow different biological pathways, and the different biological pathways are adapted on the multiple phenotypes and endotypes. It is evident that looking at these conditions, the final solution should be finding out a personalized therapy cannot be adapted to all the different phenotypes. Focusing on the clinical phenotypes, we have to look at the infections, the host response, and the development of organ dysfunction. And as you can see from this slide, when we speak about the organ dysfunction, we refer to all the different organs. We have then a respiratory phenotype, clinically speaking, that includes patients, for example, with pneumonic RDS, septic shock with a cardiovascular phenotype, where there is a cardiovascular failure, including the circulation and the heart at the same time. We have the abdominal sepsis, that is a category totally different from the respiratory while we have the localization of the sepsis into the peritoneum or involving some or one of the visceral organs. We have the kind of sepsis that occurs into the hospital, the nosocomial sepsis. And why this is important? Because we do have different phenotypes in terms of different germs respect to the infection that whose onset is in community. Then we have patients who developing sepsis became hyperlactademic, and we have patients who, during the evolution of sepsis, developed neutropenia. So the real matter is that we are quite accustomed to recognize these different categories at the bedside because they are clinical. And so it is quite easy for us having a clear-cut identification of the different conditions. But the real matter is that biologically, these clinically recognizable characteristics are biologically heterogeneous. It is important taking into account also the involvement of AI and the machine learning activities that may identify different phenotypes. And in this graph, that is a uniform manifold approximation and projection graphs in the 2 dimensions, are represented different phenotypes with different characteristics. That goes from the alpha phenotypes, where in the upper part of the graph, you identify in the left side those who are younger, whose comorbidities in general lower, and this phenotype is characterized by the lowest mortality rate. We move to an older phenotype where the patient may have more comorbidities and often renal dysfunction. And then we move to the other 2 more severe phenotypes categories, the gamma with high inflammation, pulmonary dysfunction, and indeed whose mortality is in the intermediate position. And finally, the delta one, where we do have the highest mortality rate and where the liver dysfunction, the shock, and coagulopathy are the hallmarks. But if this is true, so looking at the different phenotypes of patients, we do have also the involvement of the immune response to sepsis. And there is always a very dynamic and strong interplay between the innate and adaptive immunity. We know that innate immunity involves the neutrophils, macrophages, dendritic cells, and Kappa cells. And whilst the adaptive immunity involves lymphocytes and plasma cells for the producing antibodies also. But both cascade, both immunities are activated by the pumps and dumps coming from the pathogens and the response of the host. Ultimately, these stimulation lead to the same conclusion, the liberation of a large amount of cytokines and chemocytes complement. The microvascular dysfunction is the translation from the activation of these 2 cascade, these 2 immunities, and the liberation of the substance. Is something that may be very similar to what happens when we use the CAR T cells therapy and where we have a cytokine storm. In that case, is induced by the therapy, in this case, by the natural evolution of the sepsis syndrome. But for sure, the microvascular dysfunction, together with the inflammation and tissue injury, translate into an organ dysfunction. If we focus on the cytokine cascades that identify the major actor that plays a very important role in the development of the damage, and we may roughly categorize the 2 different phases, the early phase with hyperinflammation, and where after the pathogen recognition, we have the activation of the cells of the innate immunity, as I told you before, and through the liberation of a number of cytokines, including the TNF, tumor necrosis factor, or EL6, for example, you may induce easily an endothelial activation. I will see in a minute what it means. And the clinical recognizability at the bedside is the presence of a vasodilation and the starts of a capillary leak or coagulopathy. In the later phase, happens very often if the sepsis is persistent, a sort of shift from the hyperinflammation to the immunosuppression, where the lymphocyte express an apoptosis, and where we do have an increase the certain cytokines that, like the IL-10, the HLA, and the TNF production. But what happens in these phases? That the patient, because of the immunosuppression, has an increased infection risk, and the capability of controlling intercurring viral infection is poor, and there is always, when the situation recovers, a delay. But if we move specifically to the endothelial dysfunction that leads to the alteration of the microcirculation through the hypoperfusion mechanism, you may see that the glycocalyx structure of the endothelial cells is altered, having a shedding of the glycocalyx that causes an increased permeability. And we have at the same time the exposition of the surface of the endothelium of adhesion molecule that favors the migration of the leukocytes and their adhesion, activating a state that is a procoagulative state. And then there is the true injury where the endothelial cells are disrupted. There is a real breakdown of the barrier, and unavoidably, this has a consequence, the production of edema and microthrombosis. Which are the clinical consequences, or those that we can detect instrumentally or clinically at the bedside? We have certainly a capillary leak and the edema that we can see in the tissues. And we have, because of the chemotactic action and the exposition of the adhesion molecule, the leukocyte extravasation, the formation of thrombi, microthrombi inside the endothelial cell, inside the macrocirculation, that causes an heterogeneous and not clear perfusion. And then, because of this tissue hypoperfusion, we do have also tissue hypoxia. The other difficulty is generated by the fact that once the organ dysfunction is induced by the sepsis and the different phenotypes, we do have a sort of maleficent crosstalk over the various organs, and the infections that can occur into the lungs causing hypoxemia has logical consequences also into the brain, into the liver, or into the gut. And the substances that enter into in role are always the same: cytokines, azosomes, or metabolites, that causing also derangement of the cardiovascular function and kidney function, with alteration of the gut barrier and bacterial translocation. And the busy slide that is on the right of your screen represent how there is a constant interference and interplay between the inflammation with the liberation of certain indicators, biomarkers also, because they are certainly cytokines whose effect is a deranging effect, but also a real biomarkers for identify the condition, that large part of them translate into the high production of ferritin, that in a way intersect the immunostatus of the patients that can be very different. And then the endothelial injury that we can also suspect or better identified caused by the different immunostatus, looking at the angiopoietin 2, for example, or to the proadrenomedullin. And when the coagulation is established, the classical pathway of the coagulation and the classical hallmarks, the classical biomarkers can be looked at, like the dimer, the protein C, antithrombotic platelet. And if all these different steps that are act in concert, unfortunately, and may be substantially simultaneous, lead to the organ dysfunction that we have described several times and can be identified in case of the kidney by the lower creatinine level, increased bilirubin in case of the hepatic dysfunction, or troponin when there is an involvement of the cardiovascular systems. Just to render things even more complicated, there are the endotypes that are the fruit of the gene expression and our profiling of the gene expression that indeed specifically look the low and high expression of the molecular programs. And looking at the endotypes, we have an inflammopathic endotype whose pathway is related to the interferon signaling, to the myeloid activation and tissue injury, an adaptive one where the described immunity enter in action, or the coagulopathic situation where we do have a alteration of the coagulation, platelet activation, and complement. And finally, the metabolic one, where what is evident and its consequences is the mitochondrial dysfunction. And we have a derangement of the oxidative phosphorylation and metabolic scrap. The real matter is that these different endotypes are associated with different severity and outcomes. One of the examples of the hyperinflammatory endotype is represented by the macrophage activation-like syndromes. In this case, the activated macrophages that liberate a number of mediators, including the new ones like the CD163 or the CXCL9, is caused by a trigger. What is the trigger? The infection and the liberation of the various products of the germs, the host, dumps and pumps. And we have the key feature. This key feature are represented by a high level of ferritin that we can detect in the lab, the liver dysfunction, the refractory shock, and there is a high mortality in this case. But I alluded before for the CAR-T syndrome to the cytokine storm. The cytokine storm is the intense liberation of all the substances we have alluded to up to now that unavoidably, in conjunction, act on causing the organ injury at the various levels. But at this point, we may just see at the horizon the possibility of potential targeted therapy, for instance, for the blockade interleukin-1 or an interferon gamma pathway modulation. I will show you in the end of my presentation a couple of studies where we contributed with our group and where these different patterns are clearly shown, also with different intervenes on the therapy. If we have, as I show you, a macrophage activation-like syndrome, which is a hyperinflammatory endotype, we do have also an immunoparalysis endotype, which is an acquired state of immunosuppression. The pathophysiology is in general very often the initial hyperinflammation. And as I specified in one of my previous slides, we have also the presence of apoptosis and exhaustion of the leukocytes and myeloid dysfunction that causes an immunoparalysis. The immunoparalysis determine the depletion of the lymphocyte and monocytes and the dendritic cells, all the cells, including dysfunction of the neutrophils, that are our defenses. And these translate into the increased production of cytokines and the decrease of the HLA-DR system. The clinical consequences, I just alluded previously to that, is a delayed clearance, a poor response to therapies, and the increased mortality. Our goals is just to restore this from this immunoparalysis, the immunocompetence through the immunostimulation. Potential strategies may be the use of a blockade of interferon gamma or the use of GM-CSF. But we have mentioned several times that we have also a coagulopathic phenotype. I don't want to describe that more, but it's important to remember that the moment we have an expression of the tissue factors and the alteration of the endothelial status, the activation of the coagulation determine also the thrombin generation with deposition of fibrin and microthrombi that may occlude. Think about what happens, for instance, in an infectious RDS. We know quite well that the damage is not only into the alveolar compartment, but also includes the generation of microthrombi and arrangement of the microcirculation around the alveoli into the lung. And the story is absolutely ubiquitous. It's the same. It happens also in peripheral organs. And which are our biomarker, those substances we have to look at in order to suspect at least the presence of this coagulopathic phenotype. The dimer, the protein C, the antithrombin, and the platelets. The platelets, for sure, represent one of the simplest way to look at or hypothesize the coagulation alterations. The clinical consequence are the bleeding, dysfunction of the organ, and finally the bad outcome. So I think that we have to move from the concept of phenotype to the idea of applying a precision therapy in order to counteract a specific situation, biological situation. Let's have a look on what I really mean, following from the biological phenotype to the goal of therapy. If we look at the MALS, the hyperinflammatory states, we certainly have mentioned a few times that the ferritin or interleukin 18 or the CXCL9 may represent the biomarkers that are often predictive of the development of these or the occurrence of this syndrome. And we know that the pathway activation, this is quite common to different states, activate the cytokine storm. Can we do something at that point? Yes, because we can use a blockade of interleukin 1, a JAK inhibitor, or at times we can use the corticosteroids, which are our goal in this case, to reduce the hyperinflammation, reduce the inflammation, restore a condition that can quite stable. In the opposite situation, we do have the immunoparalysis. Can be later or can start earlier. you have always to consider a starting point that when we look at the sepsis, we have all the definition that refers to the recognition of the syndrome, but not the real start. The biological start of the sepsis is indeed never so clear and never easy to be identified. And at times, the immunoparalysis that is lately is strictly related to the fact that the sepsis started earlier and wasn't recognized before. But in this case, looking at the predictive markers, being an immunoparalysis present, we do have a leukopenia, lymphopenia. We do have a reduction of the cytokines that were very diffusely produced and liberated in the previous phases of the syndrome. And there is a depression of the HLA system with immunosuppression. And what we can do, we have to restore the immunity in this case. So in order to prevent the higher mortality rate, we need to use some inhibitors of the interferon gamma. That is one of the hallmark of the hyperinflammation. We have a blockade of specific checkpoints, and we can use also the colony stimulating factors. If we, excuse me, if we look at the endothelial function, the predictive biomarkers are the angiotensin II, the cytokine STIM, and we have repeated several times the endothelial injury is our focus. Can we do something here? Yes, we can just achieve the protection of the endothelium through the angiotensin II inhibition, through the statins and the activating protein C. Maybe some of you may remember that there were a large trial on activating protein C applied to the pattern of sepsis. And we had a distinguished publication in the New England Journal of Medicine in two different phases. At the beginning, the activated protein C, the Xigris, was capable to reduce the mortality. But when the most severe class of patients, those in septic shock, and more severe were confronted with activated protein C, unfortunately, the mortality rate did not change. But of course, there are still potentially some areas where there is a depletion of the protein C, and by using the activated one, like the meningococcemia in the infants or into the children, where should have been a room for this kind of therapy, but unfortunately it was withdrawn from the market. But our function under this condition was to protect the endothelium. Finally, we have to look at the coagulopathy. Paradoxically, this is a condition that is already established when we have a hyperinflammation or immunoparalysis, but easier to be identified through the dimer, the level of protein C that is diminished, or the antithrombin. And we do have invariably the coagulation activation. In this case, we have to restore the hemostasis. The only thing that we can do in different conditions and looking at what kind of condition prevails, if proagulation or anticoagulation situation, we have to use the anticoagulant or the antithrombin or tissue factor pathways inhibitors. What I have described can be extremely synthesized in the aphorism: right patient, right therapy, right time. Do we have practical bedside phenotyping that we can look at as a practical advice? I would say yes, because we could have a clinical assessment looking at the presence of shock, the organ dysfunction, the source control. This is easy. This is our everyday clinical life. Anybody of us is accustomed to recognize these situations. The routine laboratory can help us a lot, looking at the lactate, the CRP and procalcitonin production, the blood count complete, the coagulation profile, and the organ function looking at the different function indicators. Then we have a sort of the compromission of the immunofunction. And if we look at lymphocyte count or the HLA-DR and monocytes, we can have just an idea. The real matter is that we need to reassess our patient regularly over time. We need to reevaluate for two different reasons. The first, that the phenotypes may evolve. We have spoke several times regarding the fact that hyperinflammation state may, after a while, be transformed in the immunosuppression. And at the same time, we can look at some indicators of the inflammation and endothelial injury that invariably occur to the same indicators that I mentioned in my previous slides. And the inflammation, looking at ferritin, and in a more modern way to the CXCL9, you can have an interesting indication. Well, what are the current limitations that are big challenges that impede us or compromise or limit the precision sepsis care? As first, we do have an overlap of the different phenotypes, different biological pathways, intersects, and situations that may influence each other. Do we have tools for having a standardized bedside diagnosis looking at rapid indicators? Unfortunately, this is not the case. And we have to know that the heterogeneity with the endotypes identify various subgroups whose way to react to the insult may be different. And another important point is related to the fact that the temporal and the time dynamics may be different, not only one's respect to the other, depending upon the moment when the sepsis started, but also related to the changes in biology that can evolve rapidly over time and may change the initial situation. The real point is that do we have solid studies that validate our approaches? Unfortunately, very few. And the randomized trial are even less because there is the phenotype enrichment is not so evident, and the benefit to some extent remain totally insufficient. So we do have substantially a multidimensional phenotyping that should be essential, but not easy to achieve. Do we have future direction? Of course, we have a situation that moved from a precision critical care to sepsis. The rapid multiomics, transcriptomics, proteomics, or metabolomics may help. Another help can be given by the artificial intelligence and machine learning, where the AI may integrate complex data and may help us identifying the endotypes. The digital health, you know that, for instance, we do have in the certain fields of medicine, like the oncology, the development of digital twins. This is something that in future may help us in elaborating control groups or the specific real world elaboration of the real world data for having the digital twins to compare with our intervention. But having the capture of continuous data, a learning health system is not easy. Then we have also a number of potential point of care biomarkers that can just be at the horizon and can help us in this difficult task of identifying the syndrome and correcting promptly. Then we have a number of adaptive platform trials that, in a very sophisticated ways, test multiple therapies in biological defined groups. And finally, the systems in biology and in network medicine that help us understanding the interaction through the pathways, across pathways and organs. So we have to move from data to knowledge and from knowledge to personalized care. Before showing a couple of studies that may illustrate the point at which we have elaborated our knowledges, I want to conclude on the future management of sepsis in precision medicine. We have summarized in the previous slide the various opportunities for having an integrated approach up to reaching a targeted therapy. But we have to keep in mind once again that the sepsis is biologically heterogeneous, and not always underlying biology is so easy or to be understood or allow us to identify the right therapy, right patient at the right time. For sure, if this would be the goal, we may achieve also less adverse effect, may have a better outcome, improve the long-term recovery, shorten. So the precision of care, for sure, may translate into a better outcome intended not only in terms of mortality, but also in quality of life and recovery of the failed organs. Now, I want to show you a couple of studies where we participated and where these endotypes were identified and associated with mortality. This is the first of the two, and this is the identification of the interferon gamma-driven sepsis. And we look at the pathogenesis of sepsis, always looking at the macrophages activating syndrome and immunoparalysis that are indeed the two better and major recognized endotypes. When the interferon gamma stimulate the tissue macrophages, the macrophages release this new, relatively new CL9 mediator. What we have done in this study, I've investigated if these mechanism can define a specific and independent endotypes. And the hypothesis is that these axes may identify these specific categories of patients. This was a multi-center core study in 14 ICU in Greece, Germany, and Italy. And the population was the one of patients with sepsis, according to the sepsis 3 definition. Patients who underwent sampling for the blood, had a measurement of the several biomarkers, include those I lastly mentioned. And the total of patients that were used were more than 5,500. And this population were split in two cohorts, a discovery set and the validation set. And the interferon-driven sepsis was identified through the association of increased ferritin or the increased of HLA-DR receptors and the ratio between CD45 and CD14. That having a higher interferon gamma level above 3 picograms per ml, and CXCL9 that is above 2,004 and 200 picograms per ml. And the results of this identification of these interferon gamma-driven sepsis is that the IDS syndrome in the discovery set was occurring in the 90.9%. That were represented by more than 700 patients, and the validation set, the percentile was substantially the same, with 20%. And we had, by the way, this in the biological profile, where the IDS has a feature, the characteristic respect to the mouth. The real point is that in this dynamic, the message is that interferon gamma axis with the CXCL9 defines a reproducible and clinically relevant endotype with high mortality. And this condition is biologically different respect to the other described condition. The second trial, and in this case is a randomized trial, is very, in my opinion, very interesting because I identify the concept of the precision immunotherapy for improving the outcomes and the immunoset. This trial was designed as a multicenter randomized double-blind, double-dummy, placebo-controlled clinical trial in 6 different countries, and where the inclusion was once again the population represented by patients whose characteristics were in accordance to sepsis 3 definition. Most of these patients had community or hospital-acquired pneumonia or ventilator-associated pneumonia, bacteremia, and sepsis. And inclusion was related to immune dysregulation. One was the macrophages activation syndromes, where the blood ferritin was above 4,400, or the other, let's say, endotype is a sepsis-induced immunoparalysis where blood ferritin is above that, but the number of human leukocyte was below 5,000, and there was also an alteration of the ratio between CD45 and CD14. The study was targeted at patients with sepsis and evidence of immunodysregulation, either excessive inflammation with a macrophage activation syndrome or immunoparalysis. What has been done, that those patients that received a precision immunotherapy receive intravenous anakinra versus placebo for patients with adenomas in order to have also inhibition of the interleukin-1. Or in case of immunoparalysis, patient with for the precision immunotherapy received interferon gamma for the sepsis-induced immunoparalysis. This was compared to control, where patients receive only placebo, and the primary outcome was the achievement of at least 1.4-point decrease in the mean SOFA score from the baseline. And the findings was that the precision immunotherapy, even though there was not difference in mortality in the end, this must be clearly explained and clearly pointed out, even though, of course, this study was not targeted to show difference in mortality, but showed how the precision immunotherapy adapted to the presence of macrophage activating like syndrome and to the immunosuppression, and indeed precision immunotherapy that achieved a difference of 17.2% in terms of the decrease by 1.4 point in mean SOFA score. So these 2 studies illustrate specifically what has been discussed up to now concerning the different phenotypes. Do we have other alternatives? In other terms, could we treat independently of the endotypes in a different way? Can we use, for instance, a methodology to purify the bloodstream from the liberation from the large amount of cytokines liberated in consequence of sepsis. If we look at the recommendation of the Surviving Sepsis campaign, the answer is no. And there was also a recommendation against the use of specific filters that blocking one of the major actor of the sepsis syndrome in gram-negative infections, like the endotoxin, by using the polymyxin B filters that are applied in a hemoperfusion system and that absorb the endotoxin. So there was a clear-cut recommendation. But, for instance, and this can be certainly a collateral adjunctive therapy for improving, the negative recommendation into the Surviving Sepsis guideline couldn't look at this study that was published exactly at the same moment that the Surviving Sepsis campaign guidelines were published, and the Tigris study, and where in the patient with septic shock and identifying the opportunity window between 0.6 and 0.89 endotoxin activity, by using the absorption, M absorption through polymyxin B of the endotoxin, the final result was the achievement of the improvement in the mortality rate for those patients receiving this kind of therapy. This is just to show you how, in comparison to the identification of the various endotypes and phenotypes and specific therapies, we have also to consider probably the use of adjunctive therapies that may act in concert with the causative therapies. With these, I repeat the conclusion that is exactly the same I show in my previous slide, and I sincerely thank you for your kind attention, and I'm ready to answer your questions, if any.
Thank you, Professor Antonelli, sir. That was very nice and very insightful, looking into the future of sepsis. So I request audience, if they have any questions, please type your questions. So, sir, maybe I can just put up a couple of points for discussion. So,
Yes.
so can you just close the screen, sir, so we can see you fully?
Oh,
Thank you, sir. So, sir, maybe I can just ask a couple of points for everybody's interest. So, what do you think, sir, will be the first successful precision therapy in sepsis based on endotypes and phenotypes? Can we say something like that?
We could say something like that, even though the results, after all, are quite preliminary. You see, referring to the study with the precision therapy concerning the blocking some agents that may induce the macrophages activating syndrome or stimulate for the interferon gamma induced hyper stimulation, may achieve the two specific therapies. But in the middle of these two conditions, immunoparalysis and immunosuppression, we do have a huge number of intermediate conditions where one of the two orientation does not prevail yet, which means that we are partially in trouble until there is a clear-cut pathways and identification of the how the things are going in specific patients. We are in the middle, in between the immunosuppression and immunostimulation, and not easy to find out what to do. You can look at the indicators and biomarkers, of course, but not always the ferritin may reach these thresholds that have been identified in the study. So it's not so easy. And still, I guess, we have to insist in the going deeper into the mechanisms on that specific patients for identifying the right moment, right time, and right patients.
Thank you, sir, for the answer. So then, just related to that is how soon can we expect some kind of therapy to emerge based on precision medicine, phenotypes, endotypes?
We have, as I show you, preliminary results, and looking at that, as soon as we are capable to identify the different syndromes, the different phenotypes, we can use, for example, anakinra, if you do have a MALS syndrome. And this is already there. This is something that can we do. Which are the situation against? Of course, the difficulty and the ubiquity diagnosis that cannot be easily applied everywhere because the resources are not always the same, and there are areas where being the resources limited, I cannot even detect certain thresholds or certain indicators. In this case, the only thing that I can do is just to look at the clinical situation, implying or indirectly hypothesizing that the patient may be stimulated or having immunoparalysis. For example, looking at the number of lymphocytes. But in this case, we cannot act right away at the bedside, starting with the immunostimulation or immunosuppression, depending upon the condition of the patient. So there are a number of different limits that I try to depict in one of my last slides. So a number of very promising things, a number of very interesting perspectives, but none of them still applicable at the bedside with 100% certainty.
Thank you, sir. So then, phenotypes can change during the trajectory of illness, right? From immunostimulation to immunoparalysis or other kinds of changes can occur in the phenotype. And will we have to change the therapy also then if the phenotype is changing during the trajectory?
Theoretically, yes. We do not have any study that showed or look at the evolution in the same category of patients of the syndrome from a condition that is a hyperinflammation at the beginning to an immunosuppression after a while. However, in principle, we should change, reassessing periodically our patients. We should change the therapy depending upon the evolution of the syndrome. The hyperinflammation may persist, as well as the evolution toward to immunoparalysis. The real point is the one that I alluded to before. We never know when the sepsis syndrome started. In other terms, the only opportunity that we have is just to recognize that the patient is in sepsis when we as intensivists are on call and we are asked as a consultation into the ward, for example. But in that patient, you find that you recognize the patient is in shock or even in sepsis, but you never know when this started. And so you can have in front of you a very different pattern that should be identified. Also because the biological time and timing and evolution may be very different. So we need to honestly admit that even though there are a number of very interesting possible evolution, we still we should be very careful in choosing our therapies, individualizing our therapies, precision therapies that is really a strong background.
Thank you, sir. Sir, you showed the alpha, beta, gamma, delta phenotypes, which were published in JAMA, I think 2019 by Sim
Right.
et al. So recently, sir, in JAMA again, just in June, by I think the author's name is Yoon et al. They have published
Yes.
a study, so you might have seen that study. And in that study, sir, they have looked at 50,000 patients. And they found that these phenotypes were not reproducible across international cohorts. That is the alpha, beta, gamma, if you have seen the studies there. So any
Yes.
comment on that?
You see, it's the same comment that we have when a large study that involve a consistent number of patients is indeed not international and not multi-site. If the sites are fewer concentrated in the same country, despite the interest of the final results, you never know the real generalizability of the final results. And then, even in this case, you should be conferred, the final result should be conferred in a larger multi-center study. But as you know, accomplishing these studies never easy, and it costs a lot of money. And consequently, this is the reason, one of the reasons why the machine learning and the use of AI and digital twins it could be an option for the future.
Thank you, sir. So, final question is about the economics. So, the precision medicine relies on advanced biomarkers needing sophisticated labs. Do you think, sir, the therapies based on multi-omics technology will be affordable across the world, or there will be some limitation to its use in terms of economics?
No, I don't think that is usable for the moment because of the cost, because of the infrastructure that may be very different, and because of different economical conditions. But you know, the technology evolves, and at times what at the beginning may be very costly and very expensive may, after a time, maybe a few years, became something very cheap and diffused. In that case, the story will be much easier. But for the moment, we still do have big limitations.
Yeah. Thank you, Professor Antononi, sir. That was very nice, and we have a very good audience. And soon we shall put up the recording also for everybody to see. Thank you very much, sir. We are grateful and honored.
Was really an honor for me. Thank you so much, and I wish you a nice evening because I think that in India is evening now.
Thank you, sir. Thank you, dear audience. Bye bye. Good night to everyone.
Bye. Bye.
Bye bye, sir.